Good afternoon, everyone. Welcome to the Wellness Crisis Call Center and Response Team Community Report Back. I am Janine Spotnitz, a program planner with the Department of Health Services, and I am here with many of my colleagues who will be presenting today. We have Michael Amanero, a program planner, Robin Barney, adult family advocate, Ina Glisick, mental health program coordinator, Andrew Mendonca, behavioral health program manager, Lori Miller, substance use prevention and treatment division manager, Alondra Thompson, health program manager, and Angelina Woodbury, consumer advocate. And for our agenda for today, so we will start with some brief housekeeping items and community agreements. I will note that we had a request for access needs for audio description of all visual images shown during the webinar. So we will be doing our best to verbally say everything that is on the slides. And then we will provide an overview of our process to date. So really taking you on a journey from where we started to where we are today and sharing some relevant updates around that. And then the most of our time today, we will be spending on the findings from the community stakeholder work group meetings and surveys. So we'll be reporting back to you all of the input that we heard from you all on key areas of the program design. And then we will end with some detail around our next steps, have time for Q&A and our closing. So with that, on the housekeeping, I would just like to let everyone know. So while we had the community stakeholder report back meetings where you all broke out into breakout groups and provided feedback with a facilitator, that was the discussion portion. So our meeting today is the report back portion. So it'll be presentation format, and we welcome any questions that you have via the chat format. And most of the time will be spent presenting back to you what we heard from the work group sessions, as well as details around next steps. We had received a request for real-time captioning. That was the only access need related to language that we received. And there is a message in the chat. If you need any support with that, please reach out to Darlene Moore and she will help you access it. And we also received an access request around sharing our pronouns. So I am going to update mine in my title and encourage others to do that as well. And that was a request related to inclusivity of LGBTQ community. Okay, now I will pass it off to Michael Amanero to review the community comfort agreements.
Good afternoon. My name is Michael Amanero. My pronouns are he, him, and his. And first, our community comfort agreements begin with please use respectful language. This means no personal attacks, swearing, or criticism of self or others. Try to maintain proactive future focus. We aim to speak without offending and listen without defending. And lastly, if participants consistently disregard these agreements, they may be asked to leave. To Robin.
Okay. Are we moving along? Good afternoon, everyone. I'm Robin Barney, the Adult Family Advocate Liaison with Cal Voices and Behavioral Health Services. Glad all of you have came today. So I'm going to read the working definition of behavioral health. It's a broad term that includes the promotion of health and wellness, resilience, well-being, and health from traumatic experiences, prevention, support, and treatment for mental health and/or substance use challenges, and the support of those who experience and/or are in recovery from these conditions, along with their families and communities.
Thank you very much, Robin. And we wanted to provide that working definition because we know a lot of times we hear the term mental health used, and we really want to be sure that we're being inclusive and broad in our terminology and using the term behavioral health as Robin defined, and that includes mental health and substance use in all of the areas that she just noted here. Now we will provide an overview of our process to date and share some relevant updates. So I want to take you on a journey from where we started, which was last year in the fall, where we held community listening sessions and a survey. And we appreciate all of the input that we received from that engagement. And we heard from over 550 individuals who shared input on the initial program design of, at the time we were calling it, the Alternatives to 911. And since then have landed on the term Wellness Crisis Call Center and Response. So all of that input was used to inform a proposal that Behavioral Health Services developed and presented during the Board of Supervisors budget hearings. And that was in June 2021 of last year. And we encourage, I know many of you probably listened to that and are very familiar with it. For those of you who are not, we encourage you to go to the Wellness Crisis Call Center and Response website. We'll post a link in the chat here, and you can see the report from that previous community engagement, as well as the presentation and the proposal that was presented to the board and that the Board of Supervisors approved. In the interest of time, I'm not going to be going into detail of that today, but really do encourage you all to take a look at the website and review those materials if you have not yet. Then that brings us to August of this year, when we convened 4 more community stakeholder work groups. And that was really to build off of all of the community input that had been gathered previously and to dive deeper into particular areas related to program planning, design, and preparing for implementation. And so that brings us to today, where we are reporting back the findings from the community stakeholder work groups in August. And just as next steps, I'll be describing this later, and we will go into more detail around these next steps, but just to be clear from the onset that after this meeting, so we have County Behavioral Health Services, as well as other county departments, including County Legal Counsel and Risk Management and labor organizations, who will be reviewing the input and all of the recommendations from the community engagement, and will incorporate recommendations as appropriate and feasible. And then in particular for the recommendations around the advisory committee, and I'll discuss this in more detail shortly, it'll be the mental health board and the ad hoc committee who will review and make recommendations around that particular aspect of the work. Then before we move on into more detail for our focus for today, which is the community input gathered during this community stakeholder work group, I did just want to share one slide of findings from the initial community listening sessions. And those were the goals that we heard from community member for this program overall. And again, I will only be sharing this piece of input and encourage everyone to look at the website for more details. But from previous community input, we had heard recommended goals for this program are to safely de-escalate crises, provide linkages to accessible and affordable mental health resources to decrease repeat crises and emergency department visits, offer a response team that does not include law enforcement staffing, ensure the model is community-based, and decrease criminalization of mental health and homelessness. Okay, and then for those of you who are more visual learners, I wanted to share this slide of the process. So we heard input around particular topics related to program design from the community stakeholder work groups in August. And this is where we are now, presenting those findings. And then next, Behavioral Health Services, along with other county departments and labor organizations, will review the input and incorporate it where it's feasible and appropriate, and then finalize the program and ramp up. in order to launch the Wellness Crisis Call Center response in July of 2022. I'm going to pause. I see some questions in the chat here. A little question about if this is a report back from the work group sessions or what is actually planned for program design implementation. So yes, this is a report back from the work group sessions. And then the next steps are for the behavioral health services staff in consultation with other departments to develop actual plans for program design and implementation. And I have a very detailed slide that provides a timeline for behavioral health services next steps for that program planning. So we will get to that at the end. And yes, this webinar will be posted online. We've heard from folks that this time doesn't work for everyone, and we definitely understand that. And so want to have these materials and the presentation available for viewing. We'll post them on the website afterwards. Thank you for those great questions. So now that we've provided an overview of the process to date, we want to share some new updates. And the first update is around the geographic scope of the Wellness Crisis Call Center and response. So we heard input from community and have been working closely with the city of Sacramento and are excited to announce that this program will also serve the city of Sacramento. So that means that the program will serve the entire county of Sacramento. And we have funding for 11 total teams to date. So there were the 8 that the Board of Supervisors had approved, as I mentioned in the budget hearings earlier this year, and an additional 3 teams funded through another grant, the Crisis Care Mobile Unit. And we will be assessing and having discussions on the program size to best serve all jurisdictions within the county borders. And of course, we'll be collaborating closely with all cities and jurisdictions within the county on the planning and implementation. Then for 988, so 988 is the National Suicide Prevention Hotline. And just a brief update there that the intent is for the suicide prevention line to link calls to our call center, so the Wellness Crisis Call Center that is being developed. And I understand a lot of the details are in legislation are still being worked out, and so don't have more information about that to share at this time, but we'll definitely keep you posted as there are more updates in that area. And now I will pass it to Michael Amanero to discuss upcoming employment opportunities for this program.
Well, again, everyone. So included with the report invite was a program information flyer, and this was announcing upcoming employment opportunities. Behavioral Health Services is excited to announce upcoming employment opportunities for the Wellness Crisis Call Center and Response Team. Behavioral Health Services is committed to hiring a workforce that reflects the diversity of our community. As such, Behavioral Health Services is seeking to interview a wide-ranging pool of applicants from diverse backgrounds and different levels of clinical, professional, and/or lived behavioral health experience with high energy, compassion, and enthusiasm for public service. This flyer indicated the county, the civil service classifications listed here, and I'll just read them to you. That's Senior Behavioral Health Peer Specialist, Behavioral Health Peer Specialist, Mental Health Program Coordinator, Senior Mental Health, Coordinator, Senior Mental Health Counselor, Mental Health Counselor, Administrative Services Officers 1 and 2, and Senior Office Assistant. And then to be considered for an interview, candidates must apply at governmentjobs.com/careers/Sacramento. And this information is included on the flyer, which is also, you could find it on the website linked here as well. Detailed Wellness Crisis Call Center Response Team job descriptions will be added very soon. And as mentioned, these are upcoming positions. Some of them may not be available to apply right now, but if you use the link or you look it up on the government jobs website, if it is not available to apply, there's an option to subscribe to the position. And what that does is it gives you enter your contact information. And once that position becomes available, you'll receive an email notifying you that the county is now accepting applications for that specific position or that classification. So as I mentioned, this flyer contains useful resources as well, such as how to get a job with Sacramento County. And it includes a link to a recorded presentation called Explore Careers in Behavioral Health. So I definitely recommend going to that flyer on the website listed here to access those links. Thank you.
Great, thank you, Michael. Okay, now we will dive into the findings from the community stakeholder work group meetings. And this also includes findings from the survey. We had a total of 155 participants who responded to questions about the following 6 areas. First, community marketing and advertising, training, implementation, evaluation of the program, advisory committee for the program, and community resources. And I'd like to share a little bit more information around specifically the recommendations for the advisory committee. So the Mental Health Board created an ad hoc committee who will be responsible for integrating the previous and ongoing community input about the composition and charge of the new advisory committee. And as a reminder, the advisory committee for the Wellness Crisis Call Center and Response Team would be a subcommittee of the Mental Health Board, and its membership would be broader than existing Mental Health Board members. Its function would be to review outcomes and make program recommendations to ensure that the program meets the specific needs of the Sacramento County community. And as we noted in the email invite for our meeting today, we had sent a save the date for the Mental Health Board meeting, which is a special meeting on December 15th from 6 to 8 p.m. And during that meeting, the Mental Health Board work group will present recommendations about the Wellness Crisis Call Center and Response Advisory Committee. And so those recommendations incorporate feedback gathered by the Mental Health Board early in the year. And the feedback that we're presenting today around the advisory committee was shared earlier in September with the Mental Health Board, recognizing that the timeline for their ad hoc committee's work needed those particular subsets of the finding earlier in order to inform their review and recommendations. I know that was a little potentially complex, so I'm just going to pause and see if there is any questions. Okay, not seeing any. Then we'll move into our first section on community marketing and advertising, and I will pass it to Ina Glisick, who will present on this.
Hello, good afternoon. My name is Ina Glisick, and I'm a mental health program coordinator with Behavioral Health Services. And I'd like to share with you some findings regarding community marketing and advertising. So the following questions were asked regarding community marketing and advertising. Ideas for promoting the Wellness Crisis Call Center and Response Team, types of locations and groups which could support advertising, recommendations about how to best reach specific ethnic or cultural communities, and recommendations for images and phrases to include or avoid on advertising materials. Ideas, the first finding is regarding ideas for promoting the Wellness Crisis Center and Response Team. Social media was especially referenced as an effective method to engage youth and to destigmatize getting help with mental health needs. The second idea was to provide presentations on the WCCCRT at various locations, including schools and colleges, community-based organizations and events, community centers, businesses, crisis and respite centers, hospitals, farmers markets, and other places where community members tend to gather. Participants also offered the following specific recommendations for presentations: The recommended frequency of presentations ranged from bi-weekly to quarterly. Host an event or several events within various communities to launch the program and share information about resources. Include speakers and time for the community to ask questions. Ensure that peer specialists who can attest to the importance and effectiveness of programs like WCCCRT participate in presentations. And present information in a fun yet respectful manner that helps to reduce stigma and take seriously the needs of communities. Next, we have some more ideas for promoting the Wellness Crisis Center and Response Team. Website presence is critical. Participants stated that WCCCRT should have its own website with contact information, and every Sacramento County website should include a link to WCCCRT as a resource. Then we have traditional media, including television, newspapers, and radio stations, which is another important method for advertising. Some participants noted that TV commercial and public service announcements are visible by many viewers, and that the media outlets should be diverse to make sure that diverse communities are reached. Next, we have flyers about WCCCRT, which could be shared in a wide variety of public locations, including outside jails and hospitals, restaurants, grocery stores, and others. Additionally, some participants also recommended using promotional materials or swag, such as fridge magnets that list website and contact information. Billboards, including both print and digital billboards with images and in multiple languages, were noted as another potential advertising method. Participants noted the content should be clear, culturally relevant, fun, and relatable by using personal stories. Next, we go on to the types of location and groups which could support advertising. Community-based organizations and neighborhood associations, including community centers, behavioral health organizations, community incubator lead organizations with the Black Child Legacy Campaign, affordable housing and homeless advocates, and grassroots community groups were listed, as well as faith-based religious organizations and ethical value communities. Next, we have types of locations and groups which could support advertising, and they include the following: medical institutions and behavioral health facilities, law enforcement, services for people experiencing homelessness, professional organizations, support group, for example, for a variety of topics ranging from LGBTQIA+ to aging and dementia. Libraries and educational institutions from pre-kindergarten to colleges. County and city departments. Employees, jails and prisons. Public transportation stations. Supermarkets, marketplaces, and swap meets. Cafes, parks, and recreational venues. Beauty and nail salons and barber shops. And adult daycare centers for seniors. Recommendations about how best to reach specific ethnic and cultural communities included the following: advertised in community-based, culturally specific newsletter and cultural ethnic fraternity and sorority group councils. Outreach to impacted neighborhoods via word of mouth and pop-up events. Participate in collaborative events with emphasis in person or Zoom presentations to community and neighborhood organizations, prioritizing those of Black, Indigenous, people of color, and Asian American Pacific Islander. Use celebrities and social media influencers, local and beyond, representing different cultural communities of Sacramento, as well as music and videos to advertise. And finally, we have recommendations for images and phrases to include or avoid in advertising materials. And they are as follows. Use graphics that look inviting and affirming symbols, for example, rainbows. Images should include persons representing the community, people of color, marginalized communities. Use community-friendly language that provides a clear understanding of the service, including when to access it and what response people can expect when they call. Use a memorable image that people can remember and associate with the WCCC. Consider a mascot or a character. Images should be inclusive across socioeconomic statuses. Do not use any law enforcement personnel or imagery associated with law enforcement. Do not use doctor's codes or imagery associated with medical institutions. And finally, use safe symbols and words that convey we are here to help, not harm. Next, we are going to discuss the section on findings on training, which will be presented by Andrew Mendonca, Behavioral Health Program Manager. Thank you.
Good afternoon, everybody. My name is Dr. Andrew Mendonca, Behavioral Health Program Manager with the Sacramento County Behavioral Health Services. Today, I'll be letting you know some of the feedback that came from the community and participants in regards to training. They would like to see the staff and peers who are involved in this program receive both in the beginning and ongoing. So some of the categories of training that were identified from feedback sessions included mental health, substance use related and clinical skills, crisis de-escalation and suicide intervention, peer training, working with specific populations, program operations, and community resources. And these will all go into detail on all of these categories in just a few minutes. So the category mental health, substance use related, and clinical skills, there was a request to have emphasis on trauma-informed care, vicarious trauma training, and complex trauma. And to drill those down a little bit more, some other recommendations from participants included mental health first aid, assisted outpatient treatment, sometimes referred to as Laura's Law, substance use and abuse, ethics, boundaries, and codependency, motivational interviewing and dialectical behavioral therapy, and communication skills. Next category in regards to crisis de-escalation and suicide intervention. Under this category, there are some recommendations around risk assessments, suicide risk assessments, safety planning, and 5150 process. Also, suicide intervention and prevention. In regards to peer training, some categories of training for that included mental health, substance use, self-care training to peers. Working with specific populations, some of the areas that were identified from feedback and participants included training on cultural competence and cultural responsiveness as it relates to the impact of racialized trauma on the individual experiencing the crisis, faith-based cultures, unique needs of specific age ranges, marginalized populations such as immigrants and refugees, commercially sexually exploited children, individuals who experience human trafficking, sexual harassment, and cyberbullying. Continuing with specific populations, training specific to veterans, domestic violence, LGBTQ populations, how to work with interpreters, as well as training for interpreters on how to best assist callers experiencing a crisis, how to work with individuals living with disabilities. In the category of program operations, some training and ideas that came out of feedback from the community, including establishing and utilizing decision trees and situational procedures. This would basically involve when something happens, you move down to either A or B. Depending on what A or B is, you go to another decision tree, and it kind of helps to standardize responses, nonviolent responses, warm handoffs, and how to close services when the time comes. Informed consent and mandated reporting, and when staff need to make mandated reports and how to do that. Grievances and legal rights, and patient and disability rights. Continuing in the category of program operations, some other training suggestions included safety and defensive driving, so folks who are responding to calls, situational awareness, medication side effects and reactions, program outcomes, and law enforcement coordination and safety protocols. We'll go into a little bit more detail in this particular one next when Janine presents her section. Next category that was brought up in feedback included community resources. And in this particular area, training around familiarity with existing community resources and ability to access and conduct warm handoffs to folks that were referring for further services. I'm going to go ahead and hand it off to Janine, program planner with Behavioral Health Services. She'll be talking about implementation.
Great, thank you, Andrew. The areas of implementation that we asked for input on and we'll be covering today are listed here. So first, our risk levels and law enforcement involvement. And that really asks about at what point you think the call center staff should initiate a call to 911 and includes circumstances that mandate a call to 911, such as health emergency, fire, and danger to others. Next will be community resources and the role of us within the response team's response, followed by the identification and treatment of medical and psychiatric emergencies. And then we will share the input that we heard about the role of peers throughout all levels of risk in the response. So overall, many participants indicated that mental health and substance use concerns and crises should not be handled by law enforcement, but instead should be referred to behavioral health. And that is described in more detail in the previous community stakeholder input report. Participants addressed different considerations and perspectives about the assessment of risk and what they thought the role of law enforcement should be within the model. And I will start by saying that overall, for the first bullet point, as you see limiting law enforcement involvement, we heard many participants indicate that law enforcement involvement wasn't appropriate, as they were really intending for the Wellness Crisis Call Center and response to be a separate behavioral health and for the response, and for that to be separate and distinct from law enforcement responses. And they noted that the community callers to the Wellness Crisis Call Center response are seeking behavioral teams trained in harm reduction and de-escalation as an alternative to law enforcement response. And some participants stated that these teams would be able to de-escalate many crises most effectively without the presence of law enforcement, and expressed concern that people of colors and members of the LGBTQI+ community may be most negatively impacted by law enforcement involvement. Next, many participants indicated interest in the words of one participant, changing the current culture to ensure that the behavioral health team can take a lead in their area of expertise during crisis responses. And they described situations in which they recommended either both law enforcement and behavioral health to be sent concurrently, that's a co-response, or B, having law enforcement on standby for urgent response as needed. And they recommended centering behavioral health within these responses. For the co-response, many participants indicated certain instances where a co-response would make sense. And participants expressed different opinions about the criteria for these situations. And I'm going to discuss that in a moment around the risk levels. They also expressed different opinions about the order of coordination and referral pathway between law enforcement and behavioral health. But overall, many participants indicated a need for clear communication and coordination within this model. And one situation a participant described is if someone is threatening to jump into traffic, then it would be best for law enforcement to block and direct traffic as needed while the behavioral health team is working with the client. Then for law enforcement on standby, some participants indicated situations that may pose some risk, which is solo wellness crisis and response team may be able to de-escalate sooner, and that law enforcement should be available for an urgent response if the wellness crisis teams determine that is needed. Then for defining risk levels, many participants articulated that high risk situations are those that involve immediate danger or threats to others, and noted the importance of really considering the severity of the threat and the ability to carry it out, as well as situations in which law enforcement dispatch is legally required. So participants highlighted several considerations regarding determining risk and trying to mitigate risk. And the first one here is around preventing risk. And some participants focus on opportunities to prevent escalation of risk and safety threats by first recognizing behavioral health crises and risk factors and building awareness of those risk factors broadly to facilitate referring folks as needed for behavioral health assessments. And this participant suggested that repeat 911 calls be evaluated to identify those that may benefit from behavioral health assessments as well. Another clear theme we heard was around safety and how important it is to consider the safety of staff and of people experiencing crises. So along these lines, many participants noted the need for risk to be assessed early and often, and with appropriate behavioral health expertise to ensure that safety is a priority for the teams responding. Next, we have a threat of danger to property, and this was an area where we heard really mixed feedback, with some participants considering this as high risk and others indicating that this should be labeled moderate risk. Next, for firearms, we heard from some participants that the presence of firearms, law enforcement may be the best to call. Other participants focused on the type of risk and differentiated between whether an individual is endangering themselves or others. For example, a participant noted if a caller is in immediate risk of harming themselves, they may be best helped by a behavioral health specialist. And another stated if a caller is holding a gun to someone else, a co-response may be the best approach. Then for criminal activity, this is another area where we heard a variety of different perspectives from participants about the labeling and treatment of criminal activity. Some participants expressed that mental health providers should respond to mental health calls while law enforcement should respond to criminal activity, and that mental health providers may be unable to respond in person when there is criminal intent and a weapon. Other participants described a need to evaluate the context of behavior, and as one participant recommended, be mindful about criminalizing callers, such as those that are under the influence. So overall, throughout the discussions, and another theme we heard really is the importance of a nuanced approach. And many participants really underscored this and said that determining if law enforcement is needed can be complex, and that's particularly the case with situations of domestic violence and public safety threats. Next, we asked about referrals to and from 911, and we heard from many participants some concern about the Wellness Crisis Call Center and response teams referring to 911, as well as indicating it would be important for 911 to be able to divert calls as appropriate to this program. And one participant explained that this is really important because it will take time to build community awareness about the Wellness Crisis Call Center as a response option. So it would be helpful to have those referrals as appropriate from 911. And then finally, a participant indicated concern around risk assessments broadly and the potential that they have to reinforce biases, and requested specific consideration of this in the development of risk assessments. Next, for community resources, many participants indicated the need for additional community resources for prevention and warm handoffs, and noted that's really a critical piece of the crisis response, as well as mitigating and reducing risk and reoccurrence of crises. Many participants indicated there are systemic gaps that need to be addressed, such as support for people experiencing homelessness, for basic essential needs, and ongoing case management, as well as post-crisis needs and other community resources. And we will discuss the details around specific types of community resources later in this presentation. Then for medical and psychiatric emergencies, many participants recognize the need for an ambulance and/or EMS if there is a health or medical emergency. For example, a community member experiencing life-threatening withdrawals or suicidality. They indicated the specific need for some staff, such as behavioral health staff, to be trained in some basic medical treatments, such as CPR, and to be prepared for the possibility of a medical emergency. So they emphasize the need for a strong process to assess and divert situations that could have an emergency medical component. And a few participants asked if these teams could include a street medic or EMT to provide basic medical care as needed. Some participants also noted that it may be helpful for the teams to be able to place 5150 holds, and expressed uncertainty about which entity would transport the client in those situations. Then finally, for the role of peers, I will say that one participant indicated peers should only respond when there is not imminent danger, but most participants agreed on the importance of including peers on the response team at any level of risk. They stated that the response approach should be non-hierarchical, and it should be a team effort that's aligned with each team member's strengths. Some of the specific strengths and critical skill sets that community members noted peers bring, including serving as cultural brokers and de-escalators during crises, in addition to supporting the process of navigating resources and services, acting as life coaches, and then assisting with follow-up after crises, really building that personal connection and providing the support needed to ensure that the follow-up is effective. And then, as Andrew noted in the training section, participants here also noted the importance of supporting peers after they have addressed crises, recognizing that processing residual trauma needs support as well. And with that, I will pass it off to Lori Miller to describe the input we received around evaluation. And Lori is the Substance Use Prevention and Treatment Division Manager.
Good afternoon, everyone. I'm Lori Miller, and my pronouns are she, her, and hers. And I'm going to be talking to you this afternoon and providing some feedback and findings that we received from the community with regard to evaluations in 5 categories, which include methods of gathering feedback about the program, recommended groups to gather feedback from, other notes and considerations, such information to obtain, and recommended outcomes to track. So the first category, methods of gathering feedback about the program, include a phone call. Respondents indicated that a phone call would be really helpful because it's very personal and conversational. In addition, some participants suggested that the Wellness Crisis Call Center and Response also offer a follow-up call to ask how the caller is doing following the incident, to ask for feedback. In addition to a phone call, an online survey at the end of the call or an in-person service would be helpful, in addition to creating an app and quarterly listening sessions. The next category is recommended groups to gather feedback from. Participants indicated that recipients of program services, family members and support persons, especially those who were with the individual while they were receiving services, and providers linked to the caller. The third category was other notes of consideration, and here participants indicated it would be helpful to incentivize individuals to provide feedback or take a survey by offering gift cards or through community-based organizations, being mindful of culturally and linguistically responsive ways of obtaining feedback, and be informed of the grievance process. The next category is suggested information to obtain during the process. So demographics, level of satisfaction, parts of service that were most important, were the needs met of the individual? How did the services work for the individual? Was there coordination with other resources? What more could be done? And how could services improve in the process? Other findings included the recommended outcomes to the crisis call center services, as well as the crisis response team services. So under the crisis call center services, it would be helpful to have descriptive call metrics such as call volume, average speed of answer, average delay, average length of call, caller hang calls resolved by phone. Next, number of response teams dispatched, number of individuals connected to a crisis or hospital bed, and number of first responder initiated calls connected to care. Under the crisis response team services, it would be helpful to have the number of served per 8-hour shift, average response time, percentage of call responded within time increments such as 1 hour, 2 hours, the longest response time, and lastly, percentage of responses resolved in the community. The next category was recommended outcomes to track. And so it was recommended that we track both crisis call center and response service, crisis response services. In the areas of service was easy to access. The community feels safe with this alternative approach. Services are responsive to the community's defined needs. Reduction in law enforcement calls related to behavioral health needs. Reduction in hospitalization, incarceration, and successful navigation to behavioral health services, including mental health and substance use. So next, we're going to hear about the advisory committee, and this area will be presented to you by Angelina Woodbury, consumer advocate.
Thank you, Lori. Good afternoon, everyone. I'm Angelina Woodbury. As mentioned, I'm the Adult Consumer Advocate Liaison working with Cal Voices to Behavioral Health. My pronouns are she, her, and hers. And I'm going to be talking about the advisory committee today. And just as a reminder, it was mentioned earlier that these recommendations were provided to the Mental Health Board back in September to help color their work concerning creating this advisory body. So what we're going to cover today are the recommended types of experiences and backgrounds, such as lived experience, family members, work experience, representatives from other commissions and advisory boards, demographics and background, as well as hear some questions from community stakeholders, as well as other community input that was given. So our first findings, people felt that it was important to make sure that individuals with lived experience in behavioral health services were included on the team, especially looking at the time frame of that lived experience. They felt was important as well. So we gave the example of someone having experience with behavioral health services in the last 10 years or so, but those time frames could be flexible. Looking at people who have been arrested or formerly incarcerated, especially individuals who've been arrested or incarcerated while they were experiencing a behavioral health crisis or illness, including people who've experienced or are experiencing homelessness, as well as people with living with disabilities. That could include individuals with developmental disabilities, physical disabilities, etc. And some people recommended including the deaf community members and community members with other disabilities who have experienced police encounters. Some participants also mentioned including people who have experienced human trafficking and or elder abuse, or have been commercially sexually exploited children. Those would be the survivors of intimate partner violence. Now, in terms of family members, it was important for the community to have family members and caregivers of people who have lived experience with behavioral health issues and or incarceration. There's the work experience aspect. So participants recommended representation from people with the following types of work experience, and that can either be paid or volunteer experience, with advocacy organizations, such as those related to homelessness, behavioral health, racial equity, and public health. Behavioral health providers, such as psychiatrists, leads from respite centers, providers that operate support lines, and specialists in de-escalation, and alternative crisis services and disaster relief. So that would be people with experience like EMTs, that sort of thing. And medical organizations, such as the emergency department or other point of entry for behavioral health services. Most participants indicated that they would not recommend including individuals involved in law enforcement or criminal justice, for example, sheriff, probation, police, that sort of thing. Some did cite concerns regarding bias and a desire for people who were thinking outside of the cultural status quo. One participant noted that if an individual has former law enforcement background, they should not have served within the last 7 to 10 years to provide that distance. And there were some findings around which other county commissions and advisory boards should hold a place in the advisory council, and people brainstormed the following list: the Adult and Aging Commission, Alcohol and Drug Advisory Board, Disability Advisory Commission, First Five or the Children's Coalition, the Human Services Coordinating Council, In-Home Supportive Services Coordinating Council, the Mental Health Board, the Public Health Advisory Board, the Youth Commission, and a commission or board that addresses housing and outreach. In terms of the demographics and background, so age groups, they thought should include transition age youth, which is typically ages 14 to 24, adults and older adults. And they noted that if a youth member has former or current experience in the foster system, that should probably be included as well. They also wanted to make sure that it was inclusive of all genders, including individuals who identify as transgender, with a diverse set of gender identities included in that. Also, sexual orientation, including lesbian, gay, bisexual, and or queer identified individuals. They also noted that race, ethnicity, and culture was very important, and to include Asian American and Pacific Islanders, Black, Indigenous, and Latinx/Hispanic/Latino cultures as well. Language was also brought up, and a few participants specifically wanted to include people who speak Spanish as well as American Sign Language. And also, some participants recommended ensuring that representation in the following areas: geographic representation from various areas of Sacramento County, including the underserved areas, as well as the various cities throughout the county. They also wanted to make sure that immigrant and the refugee populations were included, as well as faith communities. And as far as questions, the stakeholders asked the following questions. So these are some things that they feel should be considered moving forward. How will members be selected? What are the expectations of the committee? What is the maximum number of members? How can people be engaged in culturally appropriate ways? And what is the composition of similar advisory bodies? And does that match what this community has been advocating for? So stakeholders thought those were important things to consider moving forward. In terms of other areas of community input, they were taking a look at recruitment. Wanted to make sure that it's proactive and intentional to ensure representation from key groups described earlier. They also want to make sure that meetings are accessible and maintain the option to join meetings virtually, example via Zoom. And they also suggested offering compensation for members' time and energy. They also, in terms of screening the candidates, wanted to use a survey method to screen advisory committee candidates and include some of the following questions. What's their professional background, job title, and lived experience? What's your purpose for being on the committee and why would you like to be on the committee? What are your overall outcomes, hopes, interests in being on the committee? And what are your thoughts around equity, inclusion, and how it applies to the work of the committee? So just a few thoughts that they had surrounding that. As far as training and education for the advisory committee members, they wanted to make sure that there was an overview of behavioral health service system, including existing services, challenges, etc., and implicit bias training, legal rights and rules for committee members, as well as training on decision-making and reaching a consensus. Community operations were also mentioned, and people wanted to encourage county behavioral health services to attend and listen and ensure the advisory board's recommendations reach decision makers. And in terms of voting ability, they wanted to make sure that everyone on the council had a voice and that those voices were honored and that committee decisions were honored. And the stakeholders had a lot to say, but I think this quote best exemplifies a summary of all of their concerns. This county and this committee can work on making this a partnership rather than a hierarchy. This hopefully will help build trust and allow clients to voice their voices without intimidation. And to that end, please check the chat. There's information about the Mental Health Board special meeting on Wednesday, December 15th from 6 to 8. They'll be having a discussion about the advisory committee, and we hope you attend that. And now we'll hear from Alondra Thompson, Health Program Manager on Community Resources.
Thank you, Angelina. Yes, my name is Alondra Thompson. My pronouns are she, her, and hers. I'm going to be speaking with you regarding the community resources. We obtained this list from Cal Voices SACMAP. And let's go. Additional community resources and existing categories. Assistance with Medi-Cal enrollment, counseling, crisis services, housing, linkage to services, mental health respite services, peer support, phone services, substance abuse treatment, suicide bereavement support, suicide prevention, support groups and trainings, and system navigation. The new resource categories and additional community resources are as follows: assistance with benefit enrollment, employment services, elderly services and resources, food, water, and other survival needs, medical care, medication, warming/cooling centers, and cleaner air centers. Resources for pets, for those that are experiencing homelessness, transportation, including transportation to shelter, interim care access, community-based conflict management, legal services, childcare, like COVID-19 resources and bereavement services, stress management, financial services, cultural brokerage, Black, Indigenous, and other people of color, immigration, resources for people with disabilities. Sorry, this chat box is coming up. I'm interrupting my slide here. That require special accommodations, services for disabled parents with able-bodied children, respite for caregivers, technology, and the community members spoke about being interested in having specific services to be culturally relevant to these types. We have racial, ethnic, linguistic populations, age-specific populations, Asian American, Native, children, Hawaiian Pacific Islander, youth, transition age, youth, TAY is the acronym, Black, African American, and of African descent. Sorry, just lost a slide.
Sorry, one moment. Yeah, the formatting for some reason wasn't appearing correctly, so I'm just reopening it. One moment here.
Problem.
There we go.
Thank you, Janine. East Asian populations, including Hmong, Latinx, Latina, Latino, Middle Eastern or Arabic speaking, Native Americans and indigenous communities, Russian speaking Slavic community, Afghan, Iranian, Indian, and American Sign Language. And the age-specific populations has been identified as children, youth, transition age youth, TAY, and adults. Populations based on specific experience continues on to deaf or hard of hearing, faith-based, families and or caregivers, parents, caregivers of youth, youth who are parents, new parents, caregivers of disabled and or older adults, current and former foster care youth, formerly incarcerated individuals, incarcerated youth and adults, immigrants, DACA, D-A-C-A, please give the acronym in the chat box, and refugee populations, LGBTQ, people experiencing homelessness, people living with disabilities and or cognitive developmental delays, perinatal, survivors of abuse, including intimate partner violence, domestic violence, elder abuse, etc., and veterans. Thank you. And Janine, will you be speaking on next steps?
Yes, thank you, Alondra.
Okay. Thank you.
And thank you everyone I see people sharing some additional input in the chat. Thank you for that. So that was an overview with, I would say, some medium level of detail of the findings that we heard from you all from the most recent series of community listening sessions, the community stakeholder work groups. And in the report that we'll be posting online, there is more detail in each of those areas. So for example, for all the resources that Alondra mentioned, where participants noted specific organizations that could provide specific types of resources, we have a list of all of the organizations that we heard from community members. So that's a great resource as well for you all to reference. Then just returning, this is the slide I presented earlier. So we heard the input that we had presented today. And then the next steps are internally for county behavioral health services to work with other county departments and labor organizations to review all of the community input and recommendations and use that to inform decisions about the program design and implementation. And then they'll be preparing for ramp up in July of 2022. And then as I noted earlier, there is a different specific for the advisory committee recommendations. So those have gone to the mental health board. The ad hoc committee work group has reviewed them and will be presenting back, as others have mentioned, at the mental health board meeting this Wednesday, December 15th. And I know there were a couple of questions in the chat around details related to implementation. I just want to remind everyone that the design and specifics about implementation have not yet been developed. And I will pass it to Michael Amanero, who will talk through the timeline for specific next steps related to the program design and implementation.
Thank you, Janine. So these are our next steps to prepare for launch. Many of this is currently what's being worked on, and included on the left side is the anticipated completion of these tasked items here, starting with the first three anticipated to be completed in January of next year. Behavioral health is currently evaluating emergency response call data to identify peak call times, and this is going to be used to inform the program's staffing model, as well as identify key geographic placement of the response teams throughout Sacramento County. The other item is develop response type protocols and workflows influenced from community input, create job descriptions and recruitment materials for the Wellness Crisis Call Center and response team employment opportunities, as mentioned earlier. Develop a training plan based on recommendations from community input, many of those highlighted earlier in the presentation. Identify space for the Wellness Crisis Call Center and response team. This one we're looking at April of 2022. Research technological solutions for a 24/7 call center response model. We anticipate completing that sometime May 2022. Develop a marketing strategy influenced by community input to ensure the program outreach and communication is done. Anticipate this completing in June of 2022, as well as expand the mental health urgent crisis care clinic to a 24/7 operation. And in June, develop a strategy for coordinating services with community-based organizations as recommended in the community input sessions. And that takes us to July 1st, our tentative program go live date. And in July of 2022, as mentioned, the Mental Health Board is creating an ad hoc work committee to integrate previous and ongoing community input in the composition and charge of the new advisory committee that will review outcomes and make program recommendations to ensure the program meets the specific needs of the Sacramento County community. Thank you.
I think Janine may have maybe frozen. Can we check in with her?
The last remaining slide was questions and answers. Please type any questions in the chat.
Looks like Janine.
Hello, are we proceeding or I don't know what's
Yeah,
happening?
it looks like Janine was frozen. I just noticed and I just texted her. So why don't we go ahead and take some of the questions in the chat. So Michael, do you want to read the questions in the chat, or would you like me or Alondra to?
Sure, if you'd like to read them.
Yeah, I can go ahead and read them. I'll start. I think the first one here is from Leslie Napper. Will the presentation be shared? Also, of the 11 teams mentioned, will peers be included on each of the 11 teams? Peers will be included in each of the 11 teams, and this presentation will be shared, and we'll put into the chat box again, the website, so that you can see any updates regarding the Wellness Crisis Call Center and Response Team. The next question, it's a statement and a question from Dr. Sacco. Gaining the community's trust starts before this program goes live. How does Behavioral Health Services plan to ensure increased transparency for the public in the rest of the design process? So as stated earlier, we will be having an ad hoc work committee, part of our mental health board, that will be ensuring that we remain transparent for the public for the rest of the design process. Hi, Janine. Sorry, I was just answering questions.
Hey, everyone. My apologies. My power shut off briefly. Thankfully, it's back on now.
So I stopped right at Dr. Sacco's feedback. The next question, Janine, is how many beds will be available per night? And we are working on a bed registry along with locations of where we can link our resources for the community when needed. So that as we are working on that. Now I can't see the question, sorry. So will the person be shared? The Jeffrey with the last name starting with the initial T. What other places can individuals be directed to? Jeffrey, can you can you expand on that question so I can make sure that we answer you correctly? If you're able to, and I know that Jeffrey is involved with a couple of meetings, so maybe we'll hear from him in a moment just to expand on, so I get make sure we get the right answer for him. And last initial starting with A, where is designing the program model step that takes into account all the design issues that were discussed, such as assessing risk, will there be a co-response model, etc. And do you want to come off and give me a little bit more context on your question around the designing of the program model steps?
Sure. I mean, we had all of those slides that talked about all the factors to consider. You know, is there going to be, the ability to do 5150? What's going to be the connection to law enforcement? How's risk going to be assessed? There were a whole number of slides about community input, about how the program was going to be developed. And you've got your next steps to prepare launch. You've got, evaluating call response data to inform the programming model, identifying geographic placement, developing response type protocols and workflows. But I don't see anywhere where you're evaluating all of those issues and developing your program model.
Yes, I'm sorry, and thank you for asking that question. As Janine stated earlier, a lot of the feedback from the report has to be reviewed by the different parts of our department. And Janine, can you give the list of everyone that will now review this report before we move forward to implementation?
Yes, absolutely. And great question, Anne. I will say that these next steps, so there's a lot more detail around them, right, that we can describe. So this brief bulleted list doesn't include everything that goes into them. But I think to your question, Anne, the 122 there under phase 1 around the developing response type protocols and workflows influenced from community input, I think that would address the areas that you were describing around the program model and using the community input that we described around implementation and risk assessment and so on. I think that would be incorporated at that time. And again, oh, sorry, go ahead.
Oh, I was just saying that is correct. To Anne's point with the workflows, such as if this, then what, weapon present, that conversation that was the input that was held earlier, discussed earlier, I should say, that's where that is the protocols and the workflows, what to do in certain situations for the program.
Okay, thank you, Michael.
Alondra, will you be reviewing additional questions in the chat? And then somebody's got their hand up with a phone number ending in 307 for a while.
I was in that space of the absence of Janine. She is now back, so I'm going to move over and be quiet. Thank you, Janine.
Thank you. Thank you, Alondra. I appreciate your support there and happy, please chime in with any responses here. So I think we left off, please let me know if there's any questions from earlier because my chat just shows questions as of 4:11 p.m. And oh, maybe I'll pause on questions from the chat because it looks like we have our speaker calling in over phone who has a question. Hello.
Hello.
You have the floor.
Name is Gene Lozano. Can you hear me?
Yes, we can hear you.
My name is Gene Lozano. I'm the chair of the County's Disability Advisory Commission. I wanted to find out a basic thing. Is there still opportunity to make some suggestions to your advisory council that you'll be developing and to expand on the resources? We have created a task force, our commission, and thank you for considering someone from our commission being on your advisory body to make some recommendations. One, we would like to find out what would be if there's an opportunity and what's the deadline to provide you with some recommendations. And for instance, very pleased about the fact that you mentioned about getting representation and addressing the issues of people who have the loss of hearing, but you also need to have about vision loss. There's effective communication issues with that population, and accessible transportation and alternative formats for people with visual issues. So we just want to find out when can we, if we can, make some suggestions for you, expansion for your consideration of things that we feel that maybe are missing, though you have pretty extensive and obviously spend a great deal of time working on it. So I'll stop talking and see if I can get a response. Thank you.
Great, thank you for that input, Gene, and we appreciate your input and all of the input that we've received during this meeting via chat. And I might defer to Lauren or someone else who's on the advisory body, the ad hoc committee who's developing recommendations for that, perhaps Angelina, but I would presume that they would take any input that you have as soon as you can provide it in advance, especially of the mental health board meeting this Wednesday, where they will be making some decisions and discussing the input received to date.
Okay, we'll see what we can do. That don't have much turnaround time. And last thing, please consider including the Sacramento County Disability Compliance Office, since they are involved with a lot of issues within the county government representing the interests of people with disabilities. Thank you.
Noted that recommendation. Thank you, Jean.
Hey, Janine, this is Karine McIntosh Sacco.
I'm on the mental health board. And just to Jeff's comment, we would welcome his committee's recommendations, and I will put in the chat how he can get those over to us.
Perfect. Thank you so much, Dr. Seiko. Okay, then the next question I see in the chat here is about outreach to the deaf community and that they may not be able to benefit from the traditional outreach strategies. So Cheryl, I cannot speak to the specific outreach that is planned at this point. I think that based on these recommendations, that the behavioral health team will be developing that plan, and absolutely welcome any input that you may have about the best organizations to partner with or methods of outreach for the deaf community. Then next from Lily Ann Glambin, and my apologies for a mispronunciation of names there. Looks like these are questions about implementation decisions around the process when people still call 911 and a dispatcher discerns it is a mental health call. Will it be forwarded here? Will it remain a 911 call? And how many calls are modeling for in year one? So those are great questions, and I don't think that there are answers for that at this time. I think that given the next steps here, that will be a part of the evaluation of call data and development of the response type protocols and workflows that will occur next year in January. Then moving on here, there's a question from Jeffrey T around navigators or attempted resource beds not available, how to coordinate what resources are used. I think maybe, Alondra, this is a question maybe you're requesting more specificity around. Not quite sure I can make out exactly the details of that. Jeffrey, if you could share some more about what you're thinking there, then we'll do our best to respond. Okay, and then we have a question from Sky I. In terms of engaging Native and Indigenous communities, will this go beyond interacting with CBOs and include building relationships with local tribes, federally and non-federally recognized? Yes, that is a great question, Sky, and I think I'll have a similar response as I did to the previous question around, I think that the broadest, most comprehensive outreach is ideal, and so any recommendation have around specific tribes, federally and non-federally recognized in Sacramento County area, any specific contacts that you would recommend for that, we would definitely welcome.
And Janine, probably before you're able to pull your chat up, there were questions around the name choice and wanting to find out more about why the name was changed, and is it possible to do something different with the name so they'll be accessible to all?
Great question, thank you. Yes, around the name, my understanding is that so alternative to 911 describes it's an alternative, but doesn't quite describe in the affirmative of what it is. And the idea behind Wellness Crisis Call Center and Response was for wellness to be a really broad term that hopefully avoids potentially some of the stigma that's associated with mental health or substance use, but can definitely include that and also be broader and expand beyond that. But please, anyone else from Behavioral Health Services who has any other detail around the thinking behind that name change, please feel free to share.
I know that there was discussion about not wanting to have 911 in the title of this program. So we didn't want to continue to say the alternative to 911. We wanted to give it a more name that is inclusive of the wellness services that we provide, as Janine stated. There's also a question about the fire department being involved. There's no information around the coordination of that.
Thank you.
All right, Ms.
And then-
Alondra, excuse me, this is Leslie Napper. Please forgive me for just jumping in. Ms. Alondra, no information around the fire department or Janine or Lori. But what other first responders, including our ambulance or EMTs? Is there anything about that?
We are discussing how to involve the EMT. We were concerned about the transportation because for the EMT and the ambulance, it's like they can only transport to the hospitals. So we're looking at other providers that will be able to be with our team. So we are in the process of working on that. With the notice that we can, if necessary, at any time, reach out to the ambulance and EMT. And when we see fit, that's currently available to our teams that will go out to these calls. Did that answer your question, Leslie?
Yes, ma'am. Thank you very much.
Sure.
Then I see a question around timeline here. And yes, want to acknowledge the several months that it took to report back and that was longer than previous report backs, and appreciate all of your patience with the scheduling, just given staff capacity and workloads, as well as our efforts to develop additional staff capacity specifically for the community engagement facilitation, as well as the analysis of the data and the writing of reports. So as you see, we have a much larger team that has been involved in this effort compared to previous efforts, and we're taking some time to develop that capacity, and appreciate all of your patience with the scheduling of this report back. And yes, I will say that
Oh no, Janine, you're frozen again.
She's been having power issues at her house. So Alondra or Michael, if you want to take.
Oh,
someone else want to add something?
You had froze for just a moment, Janine, so we were going to take over again, but we just wanted to make sure you're back, so that's great.
Okay, were you able to hear my response there?
It would be great if you can do it over again, just in case.
Sure. Yes, so I was just thanking everyone for your patience with the scheduling of this report back, and noting that we had been in a process of building additional staff capacity to do the data analysis and the writing of the report. And so that was a longer timeline for that process, but it's great to be able to build those skills more broadly within health services. So we appreciate your patience with that timeline. And also I can assure you that the timeline here is what we will plan to implement. So what you see on this slide are the dates that we are planning for next year for the various milestones.
There is a person that's had his or her hand up for a moment. The last numbers of that telephone number are 156. Would you like to go ahead and come off of mute and ask your question?
Yes, my name is Carol. I was just wondering, I know there aren't many models out there, but St. Paul, Minnesota has already opened up what they've been working on this kind of project. And have you looked at that or talked to anyone about what they've done? Because my thinking is, why reinvent the wheel if it's already there? There might be things in there that you want. Has anybody looked at that?
Great feedback, Carol. We have looked at the Georgia model, but I would be more than willing to look into, can you state the name of the project you just referenced again for me?
St. Paul, Minnesota, where they had all the trouble and they decided to do this, and they've already implemented it, which is pretty fast. But I just wondered, it seems like they're very happy with it. So I was just wondering if you looked at it.
We will take a look at that. Thank you for that input. I'm sorry.
I'm happy to just jump in. I think Janine might have been trying, I know she's having some connectivity issue. I'm Kelly Weaver, a division manager with behavioral health, work with Lori and Alondra and Janine and Michael. And in addition to the Georgia model, which is a nationally recognized model called Crisis Now, we also met with the folks in Oregon that run the Cahoots model and folks in Denver that run a STAR model, and did quite a bit of research in other models that roll out in other states. But happy to continue to look, and as we are happy and open to hearing more feedback. I also want to just jump in on, I know there's a number of inquiries around the naming, the nomenclature of the program. We are definitely open to hearing what folks, thoughts are around naming this program. We agree the name is important. We want it to be reflective of our community and reflective of this program. And we want it to be accessible. So we are all happy to hear suggestions on how to get input from folks. We want to get the program implemented in a timely fashion. So we know that the naming convention is really important for marketing. So we need that soon. So happy to hear suggestions on direction from you all in terms of naming the program.
And Dr. Sacco did put information on how to provide input to the board in our chat box. Thanks.
Hi.
Go ahead, Kelly.
I'm sorry. There was a comment pertaining to program objectives and goals. And that is, yes, absolutely. We want to have very specific targeted goals, and part of the advisory committee as we'll be looking at the feedback that in the report regarding what areas, and I think they did an overview of that section of the feedback that we received. We want to put all that together with input from the advisory committee on what types of outcomes do we want to be able to measure. We're as the timeline, there's a part of the timeline we're looking at software and data collection, and then really build a report that can get us regular outcomes, looking at it day to day, month to month, quarter to quarter, and then annual report. So we definitely want to hear from you what kinds of outcomes you would like to see. We've already gotten some of that feedback, and then that's part of the role of the advisory committee is to help us look at the evaluation component of this program and get regular and ongoing feedback on what's considered successful outcomes and what adjustments need to be made in the program to make sure we're meeting those objectives.
Thank you, Kelly. And I see we have hands raised. I think these are the callers that we've already heard from on the phone. So I'm going to lower your hands, but please, if anyone is on the phone and would like to comment, please do raise your hand. Okay, then we have a question from Jeffrey T about how we are keeping in contact with people who likely have no cell phone or addresses, and a note around mental health beds and what the access looks like for them and what would be available for mental health. Is that something, Kelly or Alondra, that you might be able to speak to?
A component to the call center response team, it's a three-pronged approach that we went to our board and made a recommendation that was approved, was to have a 24/7 call response, a 24/7 mobile response team, and we expanded our local mental health urgent care clinic to 24/7. So that's going live early to 2022. That will be another resource that the teams can leverage for additional support after hours. We are also looking at our relationships with our local hospitals, crisis stabilization units. Here locally, we have our CSU that's partnered with us, Dignity San Juan. We also work closely with, we have respite centers that we contract with, and looking at opportunities to potentially expand those down the road. but that's one of the things that we'd want to look at in terms of what we're finding as gaps. For future programming and planning is look at gap analysis in terms of what the teams are finding, what's needed, and what's still missing. But we are looking at where we have 24/7 access, and the urgent care is the third prong to this model and this approach.
Great, thank you. And I'm seeing some positive feedback in the chat. Love the extension of mental health urgent care center versus more beds. Then a question from Dr. Seiko about if we could say more about how the program will collaborate with the city of Sacramento. And I could say broadly that the program will include all areas within the county. And as a part of that will involve collaboration with the city of Sacramento, as well as the other cities within the county jurisdiction. And I think that may be all the detail that we have at this point about that. Then we also have interest in knowing how soon and where the location of the video will be made available from Ryan McClinton. And I think it's realistic that we'd be able to post this and the slides by Wednesday, and that will be at the Wellness Crisis Call Center and Response website, and we can share the link in the chat. And you can also Google Wellness Crisis Call Center Sacramento County, and you should be able to find it that way as well. Okay, and then we have a request to post in the chat again where people should submit their comments or suggestions about the program name. So someone could please post that again.
Janine, there's a question about keeping in contact with people likely not having a cell phone or an address. The respond to 10 years closed mental health beds. What and where will people be housed? Not like Kaiser's, into Woodland Mental Facilities, new one in Davis. What's available for mental health? And that's from Jeffrey, last initial T.
Thank you, Alondra. Yeah, I think we addressed the second part of that question, but the first part, that is, I would acknowledge that as an ongoing challenge of being able to follow up with folks who don't have addresses or cell phones. So that's an area where I think we'll have to try different approaches. I know that will be also something that other teams who are working with people experiencing homelessness, including the encampment team, will be working on. And there are ways that they have developed to try to follow up with people. For example, people tend to stay in a particular spot at a particular time of day, and so they can find them there or connect with service providers who have contact with that individual in order to follow up with them. So there's a variety of solutions, but really requires being creative to try to address those challenges. And I see Angela Talent, your hand. Feel free to unmute and ask your question.
Hi, Janine. Thank you. This is Angela. I'm also on the DAC, and I'm hoping that we could potentially get an email copy of the presentation, since what I think I heard you say was that we needed to have information ready for the Wednesday night meeting for recommendations from the DAC. Is there a way we can coordinate getting a copy of the presentation tonight or tomorrow, early tomorrow?
Yes, we can do that. Angela, if you want to drop your email in the chat there.
Will do. Thank you.
Absolutely. And then I think there's a question from Kenny B around connection to specific organizations for care. And I would say at that point, I think that level of detail is something that will be determined in the planning process around the specific linkages to community organizations. And we can ensure that your recommendations and questions are included in the list. And also we'll note that in the report of community input that we have a lot of different excellent specific recommendations about organizations to provide referrals and warm handoffs too.
Janine, I can actually respond to
Thank
that
you,
particular question because those are existing providers in our system. Absolutely, that is a component to this model, that folks that are linked already to services within county mental health will be reconnected. For those individuals that call seeking assistance, staff will be trained and equipped with connecting folks to our full array of mental health services across the county of individuals of all ages. So the two that were mentioned in your inquiry, River Oak as well as Visions, those would be examples of providers that we would absolutely be able to connect for those folks that are eligible for those services. That'll absolutely be a component. We will also be leveraging our electronic health record, and we will know when folks are linked. And part of the response will be in coordinating with their current provider who has a relationship with these folks to help in resolving the crisis and have a support plan following up post-crisis.
This is Leslie Napper. Please forgive me for interrupting this way, everyone. Is this limited to for people who are Medi-Cal or Medicare eligible? Does this extend out to others?
Yes, it does, Leslie. I am speaking specifically to coordinating efforts within the county system. We would not have access to private insurance like their private therapist, but we would certainly work to coordinate if somebody has a private therapist as a follow-up plan. Absolutely. But yeah, no, this is open to the community. And we will respond to all that need assistance.
Thank you. That's good to hear. Thank you.
Dr. Sacco, I see your hand up. Is this a question that you have, or have you already stated your response? Have to unmute yourself.
My questions have been answered. Thanks for checking in, Alondra.
Yes.
Great. And then I see a question from Laurel B asking if this is a pilot project. If yes, how long is the pilot? If no, is the county funding permanent? So it's my understanding this is now a program. It's not a pilot. This is a program. Oh, Kelly, please set us straight. That's record.
No, you are right. It's not. We're not moving forward as a pilot. Our budgets are annualized. I think Siobhan's still on here. I want to make sure I'm saying the right thing, but our budgets are. We go back to the board every year to get programs renewed. But we are. This is a funded program currently, and we go back to the board every year for to renew our budgets. So we are not moving out with a pilot. This is a fully funded program.
Great, and not seeing any other questions in the chat or any other hands raised, we'll just lift up some appreciation of behavioral health services staff hard work and commitment to the program design, and some resources being shared about other meetings. So with that, I think we can end the meeting and give you all some time in your day back. And really want to thank you all very much for everyone, especially who provided input that we presented on today. We really appreciate you taking the time to help make sure that this program is a success and able to serve all of our diverse communities in Sacramento County. And it takes partnership with the community, with you all, in order to make that happen. So thank you all very much for that. And also want to just make sure everyone is staying safe out there. The weather is quite bad right now, very windy, and there's a wind advisory on now and rolling power outages. So just hope that everyone's staying safe.
Hey, Janine, I'm sorry to interrupt you. I do have a community member signed in that has a question. Do we have time for one more?
We do, please. Yes, please, community member, please feel free to unmute yourself with your question.
Absolutely. Hi, my name is Desantois. I was curious, have you all had conversations with emergency departments to see how they're willing to maybe lend resources to help develop the program? And then also, please consider making the call center a point of contact. There's a lot of programs who cannot provide services unless that person is currently on a 5150. So diverting some of those points of contact to the cost center, I think would be helpful.
Thank you for that input and question. Kelly, was there a part of that you might be able to address? No? Okay. Yeah, I think that the conversations with the emergency department will be part of the next stage of planning. So as you see here in the steps for preparing for launch, I think that would be included within that preparation. But I think that's an important point, and we do plan to coordinate with partners closely, including emergency departments.
I'll just
and
add,
then yes,
add
please.
that we meet with hospital systems every other week, and they're quite aware about what we're doing, and we're always working to coordinate our activities with the hospital systems as well. So we certainly look forward to any sort of collaboration we might be able to figure out on this project as well. I think they're very excited around the other component that we talked about expanding, which was our 24/7 urgent care clinic. So I think that's another way that they're looking forward to some collaboration as well, so that there's other places for folks to go rather than the emergency departments.
Great, thank you for that. And then it
Thank
looks like
you.
we might have one last comment here. I see a hand raised from Jeffrey T. Jeffrey, would you like to unmute yourself and ask your question?
Jeffrey, I'm not sure if you're trying to speak to us, but you're still on mute.
Oh, see, his hand was down. I think we may have answered the question there. Okay, then with that, I will again thank everyone for your time today and wish you all well for the rest of your day. Take care, everyone.
Thank you, Janine.